So we are starting to discuss valvular heart diseases. First is aortic stenosis. So aortic stenosis, we have already discussed what is the murmur in aortic stenosis. It's going to be a crescendo, decrescendo murmur, and it is a systolic murmur. What are the etiologies of aortic stenosis? It can be a degenerative valve in case of senile degeneration, that means in old age, or a bicuspid aortic valve, which can also be associated with Turner syndrome, right? So what are the triad or presentation of aortic stenosis? It's angina, syncope, and dyspnea. Now all these three symptoms will not present earlier itself. It's first angina, then it can go in for a syncope, finally the patient can go in for dyspnea. So you don't wait until dyspnea happens to diagnose it as aortic stenosis from the triad. You have to early on itself you have to think about any cardiac pathology and do an echo that will give you an idea whether the patient is having a stenosed aortic valve. Severe aortic stenosis is when the valve area is less than 1 centimeter square. So in symptomatic patients, you go for surgery. Okay, so the treatment in aortic stenosis is surgery, and it is in symptomatic patients. In asymptomatic patients, when they do not have any other underlying cardiac pathology or any coexisting lesions, you may ignore that. Otherwise, in symptomatic patients, aortic stenosis does require valve replacement. Before doing a valve replacement, always do an angiogram, right? Coronary angiogram. Why do you need an angiogram prior to aortic valve replacement? Is because you may have undiagnosed, coronary lesions. So if that is there, anyway you are going for valve replacement. So you may take that patient for CABG along with that valve replacement. Now, another thing is, if the patient of aortic stenosis have atrial fibrillation, it's going to be even more fatal because that is going to highly compromise the cardiac output. Another syndromic association of aortic stenosis is called Hades syndrome, wherein aortic stenosis with angiodysplasia. So the patient may present actually with GI bleed, and then you may suspect, this rare association, and then maybe find the patient to have aortic stenosis. And what are the other findings? You have an S3, S4, S3 is due to overfilling of the ventricle. Because there is aortic stenosis, the ventricle cannot empty its whole blood into the aorta. So the ventricle is already like overfilled. That means it can go in for left ventricular failure, and it can lead to S3. S4 is when due to chronic aortic stenosis, the left ventricle can go in for left ventricular hypertrophy, and the left ventricle can become non-compliant. So the atria contracts against this non-compliant ventricle, that leads to S4. It can have an ejection click. The murmur, classical is crescendo decrescendo murmur in the aortic area, which is right upper sternal border. Now, in symptomatic patients, the only treatment is valve replacement. But if AVR, aortic valve replacement, is contraindicated, you go for TAVR, transcatheter aortic valve replacement. Always do angiogram prior to TAVR or AVR so that you can, manage the coronaries as well. This I've just added so that you know that in ECG, when you find this pattern, that means in V6 and all, there is a long R wave, there is a T inversion, okay, slight ST depression. This is not actually a non-ST elevation MI. This is actually LVH strain pattern, because LVH criteria from LVH voltage criteria is there is R wave progression, right? So V1 or V2 S wave plus V5 or V6 R wave, whichever is bigger, more than 7 big squares, that is going to be 35 mm. That is called LVH by voltage criteria. So in LVH, you can also get this thing called T inversions and ST depression. This is nothing but an LVH strain pattern. So you have to identify that from the ECG and do not misdiagnose it as NSTEMI. Now I've just added the etiologies of other valvular lesions because valvular lesions, we have to know the murmurs, we have to know the treatment because it's going to be valve replacement. We just have to know the etiology. That is main important as far as the exam point of view is concerned. So aortic stenosis was degeneration and bicuspid aortic valve. Aortic regurgitation can be due to aortic root dilatation. Now that can be seen in Marfan syndrome. It can be seen in tertiary syphilis when there is cardiac involvement and ankylosing spondylitis as well. Mitral stenosis, mainly rheumatic heart disease. Rheumatic heart disease can affect any valve, but mainly affects mitral valve, and also its mitral stenosis more common than regurgitation. So mitral regurgitation again, it can be rheumatic heart disease or infective endocarditis. Now, infective endocarditis also most commonly affect mitral valve, and it is a regurgitant lesion going to be in IV drug abuses. In IV drug abuses, infective endocarditis affect the tricuspid valve with the tricuspid regurgitation because they are having the venous access, so it goes to the right side. That is why it's a tricuspid valve. Otherwise, most common affected valve in case of infective endocarditis is mitral valve and mitral regurgitation. MVP, mitral valve prolapse, can present with mitral regurgitation. See, in Marfan syndrome, the most common thing is aortic root dilatation, but Marfan syndrome can also have MVP. Okay, and papillary muscle rupture post MI. So this is one complication post MI. Post MI, you can have a papillary muscle rupture, which leads to new onset mitral regurgitant murmur. Now, how do you give anticoagulation post valve replacement? Post valve replacement, you definitely have to give anticoagulation. For bioprosthetic valve, it's 3 to 6 months. Otherwise, for mechanical valve, it's going to be lifelong. And for mitral valve, the target INR is kept at 2.5 to 3.5. For aortic valve, it's kept a little bit lower, that is 2 to 3. So that is regarding valve lesions. Now let's come to pulse. What are the pulse wave and what are the abnormalities that you get in a pulse? Pulse wave has a systolic phase, a diastolic phase, and in the diastolic phase there is a dicrotic notch. Okay, this is the normal pulse wave. Now there are some abnormalities that you can get in a pulse wave. That is small and weak pulse, slow rising pulse. That is called pulsus parvus. Parvus means low. Et tardus, that means slow rising, late peaking. Okay, that you can get in case of aortic stenosis. Large and bounding pulse. So this is in case of aortic stenosis. Large and bounding pulse or collapsing pulse is in case of aortic regurgitation. Bispherian pulse can be due to a combination of stenosis plus regurgitation. That means you have a double systolic peak. Then pulses alternance means there is alternating in volumes of that pulse. There's a high volume, low volume, high volume, low volume. Now, the same thing if it happens in an ECG where the electrical component is alternating, it's called electrical alternance. You can see that in cardiac tamponade. Okay. So the Bispherian pulse is a double peaking pulse, okay, double systolic peak. It can be pure aortic regurgitation or a combined aortic stenosis plus regurgitation. Pulses alternance is varying in amplitude from beat to beat, but the rhythm is basically regular. Okay, it indicates left ventricular failure, so it can be accompanied by a S3. Bigeminal pulse means it's a normal wave followed by an abnormal wave, okay, because it's normal beat alternating with a premature contraction, so the rhythm is abnormal here. In pulses alternance, rhythm was normal, only the volume was alternating. Okay, so so that is bigeminy and pulses alternance. What is pulses paradoxus? You might have heard the term, but the pulses paradoxus is a misnomer. It's actually an exaggeration of a normal physiological event. Actually, when there is inspiration, what happens is the right sided filling, right sided volume increases. So, comparatively, the left sided volume decreases, right? Since the left sided volume is decreasing, there is slight fall in SBP. right? Because SBP, systolic blood pressure, is a direct reflection of left ventricular and diastolic volume. Now, since during inspiration the left sided volume is slightly reduced, the SBP is going to fall. Now, in pulses paradoxes, what happens is this fall is going to be even more exaggerated. It's going to be more than 10 millimeters mercury, and it's seen in case of cardiac tamponade, because in cardiac tamponade there is interventricular interdependence. That means you have the ventricles. In cardiac tamponade, what is happening is the pericardial space will be completely filled with blood, so it's trying to, you know, uh, trying to stop the blood from being getting filled into the ventricles. So this is cardiac tamponade. So what happens is during inspiration, the right-sided filling, as expected, will increase. So this right ventricle will be more pushed towards the left ventricle. So the left ventricular volume will be even more reduced, much reduced than the normal case. So SBP fall will be even more pronounced. That is more than 10 millimeter mercury. That is in case of cardiac tamponade, and it's called pulsus paradoxus. That was regarding pulse, different pulse waves you have seen. Now let's see JVP. We have earlier itself discussed JVP is going to be the reflection of right atrial pressure changes. And it has an A wave, a C wave, a V wave, an X descent, and Y descent. Now, what are the basis of all these waves? A wave is going to be atrial contraction. Now, after the atria contracts, after the atria empties all its blood into the ventricle, what happens is the AV valve, that is atrioventricular valve, that is mitral and tricuspid, will close, and the pressure inside the atria starts to drop. That is when you have X descent. X descent. Now, when the atria is trying to, relax, during ventricular contraction, the tricuspid slightly pushes into the atria, slightly raising the pressure of the right atrium. That is why you have a C wave, which is called the dicrotic notch. Hmm? Now, once the atria is completely relaxed, the increase in volume happens. That is atrial filling. That is a volume filling inside the atria, which is called V wave. Now, once the volume builds up in the atria, at one point the tricuspid valve will open, and all the blood will get emptied into the ventricle, and that is called V wave. Okay, that is called V wave. So you have A wave, C wave, V wave, and X descent and Y descent. You can just see how they are corresponding to the ECG. P wave is going to be atrial depolarization. So atrial contraction will be slightly delayed. The actual mechanical event will be slightly delayed. QRS is going to be ventricular depolarization. So X descent is when you have the ventricular contraction or the atrial relaxation, because atrial relaxation overlaps with the ventricular contraction. Then you have T wave, which is ventricular repolarization. During ventricular repolarization, the atria empties the blood into the ventricle. So at the end of T wave, you have the tricuspid being opened and the atria emptying all its blood, and there you have the Y wave. Okay. So, what are the abnormalities that you can get in case of this JVP? Where do you get absent A wave? Absent A wave is seen in atrial fibrillation, because atrial contraction is not effective in case of atrial fibrillation. So, you'll have absent A wave. A wave is corresponding to atrial contraction. Large A wave is when the pressure inside the atria will be even more built up. So that is when atria is contracting against a stenosed valve, right? So it can be in case of a tricuspid stenosis or even pulmonary stenosis. Canon A wave, again, it can be in case of complete heart block. Okay. Tall V wave. Now, tall V wave is due to volume filling. So when there is overwhelming volume in the right atrium due to a regurgitant lesion of the tricuspid valve, you can get a tall V wave. That is in tricuspid regurgitation. Now, what about X descent, rapid X descent, and rapid Y descent? This can be seen in case of constrictive pericarditis. Constrictive pericarditis, you can get rapid X and rapid Y descent. Now the Y wave can be absent or flat in case of cardiac tamponade. So in cardiac tamponade also, X descent can be rapid, but Y descent is absent or flat. So these are the abnormalities that you get in case of JVP. Okay, I've just added that again. Absent A wave in case of AF, large A wave in case of a stenotic tricuspid valve, Canon A wave in case of complete heart block. This is a previous year question. Tall V wave in case of tricuspid regurgitation, rapid X and Y descent in case of constrictive pericarditis, absent Y wave or flat Y wave in case of cardiac tamponade. So this I have just added an image so that you know what is happening in constrictive pericarditis as well as cardiac tamponade. So this is a normal JVP. In constrictive pericarditis, you can see that X and Y are more steeper and more, rapid. In tamponade, what is happening? The X can be a little bit steeper, but Y is a bit absent. Because in cardiac tamponade, the atria cannot empty its blood into the ventricle because of, you know, ventricle is going to be non-compliant, right? Because the due to tamponade effect, the filling into the ventricle will be highly compromised. So the Y wave will be flat. You can't empty that whole blood at one go into the left ventricle, left as well as right ventricle. JVP mainly we're talking about the right side. Now there is another important thing regarding JVP that is called Kussmaul sign. What is Kussmaul sign? It's paradoxical rise in JVP during inspiration. Normally during inspiration, what is happening? There is fall in JVP during inspiration because the pressure will be a bit reduced on the right side. But if there is paradoxical rise instead of fall, there is rise in JVP during inspiration is called Kussmaul sign, and it is very classical of constrictive pericarditis. It can also be seen in restrictive cardiomyopathy, but if you are asked Kussmaul sign is seen in then you have to tell that it is constrictive pericarditis because the ventricles fail to accommodate the increased volume of blood. Because of stiff ventricles, they fail to accommodate that. So there is paradoxical rise in the JVP during inspiration, right? Now, what is hepatojugular reflex? Hepatojugular reflex is just a reflex so that you confirm that it's JVP and not carotid pulse that you are measuring. So you're slightly compressing over the abdomen, over the liver, and then you can see a slight rise in JVP. That is called hepatojugular reflex. It's normally seen in JVP. Now, the most important topic in all this thing, cardiology, is understanding ECG. You have to know the normal so that you understand, you can see, abnormal things. You can have 100 different types of normal ECG. That is more important to understand. You will be very easy to pick up the ST elevation. You will be able to find out ST depressions. You will be able to find out electrical alternance or maybe irregular rhythm as in case of AF, but you will miss normal ECG. Okay, that is important. So let's see what are the things that you need to know. So ECG, you have. Let me see what all we need to know. We have to know what are the waves. We have to know what are segments, and we have to know what are intervals. Okay, so what are waves? Waves is anything that above that baseline, right? So here this dotted line is the baseline, and anything above that is going to be your waves. So you have a P wave, a P wave, a QRS complex, and a T wave. What is P wave? P wave is atrial depolarization. What is QRS? Ventricular depolarization. What is T wave? Ventricular repolarization. Okay, easy. Now, what is segment? Segment is going to be isoelectric. That means it is lying over that flat baseline. So you have a PR segment which is corresponding to the AV nodal delay. Okay, this is the AV nodal delay or the AV nodal conduction. Okay, PR. So PR prolonged means the heart rate is going to be low. PR is very slow means it is going to be tachycardia. Then you have the ST segment. You're mainly going to see if there is ST elevation or ST depression. Okay. So those are your segments. How about intervals? Intervals means intervals is going to be a combination of wave along with segment. So PR interval is P wave along with PR segment. So it is going to comprise the time that it takes from SA node to reach until the AV node and till the ventricles. Not the ventricular depolarization hasn't started, but the whole time. Okay, so that is going to be PR interval. PR interval can be prolonged in case of heart blocks, right? It can be PR interval can be fixed and prolonged in case of first degree heart block. It can be variable in case of second degree heart block, right? In complete heart block, there is not going to be any correlation with P and QRS. It's going to be independent from each other. Okay, that is the importance of PR interval. What about QT interval? QT again is going to be QRS along with ST segment along with T wave also. It is until the end of T wave. QT interval. So QT interval prolongation can predispose to torsades pointus, and there are many drugs which are non-culprits like amiodarone, sotalol, antidepressants, antibiotics like erythromycin. Okay, there is a whole list of drugs which can predispose to this. So if you are prescribing a drug to a patient whose QT is already prolonged, you have to be very careful because it can predispose to torsades pointus. It's a fatal ventricular arrhythmia. It's a type of VT, a polymorphic VT, and the patient can go in for cardiac arrest as well. Next is your RR interval. Now, RR interval is not in this one cardiac cycle. RR interval is between two cardiac cycles. So you will have another P wave, another QRS, and another T wave. So in between these two, that is called RR interval. Why do you need to know RR interval? So that you can calculate the rate from the ECG. Okay, so that is regarding the waves, the segments, and intervals. Now, to read an ECG, you have to know the dimensions of that squares that you have in the ECG strip. So this one small box is going to be 40 milliseconds in duration. So along the x-axis is going to be duration. Along y-axis it's going to be amplitude, and the amplitude is going to be 0.1 millivolt. Okay, and 5 by 5 small squares is going to give you a big square. So you can do the math. So in x-axis it is going to be 200 millisecond or zero point 0.2 second, and the amplitude is going to be 0.5 millivolt. Okay, this is fixed in case of normal calibration that we have. This can be varied if you change the calibration, but usually this is what we take. Now, from the ECG, what are the things that you first calculate? First, you look for the rhythm strip. So downside of that ECG strip, apart from your limb leads, apart from your augmented limb leads, apart from your chest leads, you will have usually the lead 2 given as a long strip, that is called rhythm strip. You will look for RR intervals, whether it is fixed. If the RR intervals is regular, it's called regular rhythm. Now, what is sinus rhythm? Sinus rhythm means the electrical potential is beginning at the SA node and then it travels through the AV node and the conduction pathway as usual, like the bundle of the right and left bundle and the Purkinje fibers, and then to the ventricular wall. So this is the normal conduction mechanism. If it follows the normal conduction mechanism, it's called normal sinus rhythm. That you can see from the RR intervals. If the RR interval is fixed, it's called regular. If the every P wave is followed by QRS, it's called sinus rhythm. So regular and normal sinus rhythm. That's how you comment. NSR means normal sinus rhythm. Okay, that is regarding the rhythm. Now you will see the rate. Rate is again based on RR intervals. So in the RR intervals, you will calculate the number of large squares. 300 divided by that number of large squares is going to be your rate. Suppose your number of large squares is 6. then your rate is going to be 300 divided by 6, it's going to be 50. It's slightly bradycardia, right? Because 60 to 100 is going to be normal. Okay. Now, then you look for cardiac axis. Now, cardiac axis is a bit confusing, but let me make it clear. Normal cardiac axis is going to be minus 30 to 90. Let me tell you how to calculate the cardiac axis. So before you understand how to calculate the axis, you have to know how normally all the leads are like placed. So lead 1 is directed along the zero axis, because lead one is placed between right arm and left arm, and it is directed from the right arm to the left arm. So the direction is going to be like this, because we are placing everything from a single starting point, right? So we are placing it like this along the 0 degree axis, because for convenience we are taking everything along the x-axis as 0 degree, everything clockwise as positive, everything anti-clockwise as negative. Okay, so the lead 1 is going to be along 0 degree. Now how is lead 2 placed? Lead 2 is placed between a right arm and left foot, with right arm with directed from right arm to left foot. So again, if you're starting from one point, it's going to be along plus 60, right? Lead 3 is from left arm to left foot, with it being directed from left arm to left foot. So if you are placing it from one single point, it's going to be at plus 120 degree, because that's how you place vectors. Okay, it's mathematics. Now how is AVF placed? AVF is placed so that the foot becomes positive and the negative is placed between the other two limbs, like right arm and left arm. So it is directed exactly downwards, that is along plus 90. Okay, plus 90, that is AVF. Now how is AVL placed? How is AVL placed? AVL is going to be over the left arm. It's going to be positive, and the other two limbs will be negative, so that it is directed like this. So if you're starting from one single point, it's going to be minus 30 degree. AVR, just like that, is going to be exactly opposite to the resultant axis of this cardiac. That is why every wave in AVR is going to be negative. So in AVR, you are not actually bothering the AVR in ECG. You're just seeing whether all the waves in AVR is going to be negative. Otherwise, it means that you have somewhere misplaced the leads. Okay, AVR has to be negative. So this is the normal thing, normal happening in the heart. And the resultant of all this is going to be somewhere between this minus 30 and plus 90. That is called the normal cardiac axis. Now we'll see when we say there is left axis deviation, when we say there is right axis deviation. So suppose we are calculating the axis like this, okay? We are seeing lead 1, we are seeing lead 2, and we are seeing lead 3. Okay, I'm giving you an example. Okay, either you can look at 1 2 3, or you can look at 1 2 and AVF. Okay, that also is possible. Or if 2 and 3 is going to be equivocal or you're doubtful, you can again cross check with AVF. So these are the main things you see. Suppose your lead 1 is showing like this, that means there is only a positive deflection, that means it is a positive wave. When it is a positive wave, lead 1 is placed normally. Lead 1 is placed as it should be, like along the 0 degree. Lead 2, here you can see there is only a negative deflection, or it can be that the positive deflection is slightly less than the negative deflection, or resultant is more negative. That means it is negative. So usually lead 2 is placed at plus 60. So if it is negative, you have to place it exactly opposite to it, right? Like this. So here it will be like this. Okay. Lead 3 again here is positive. So it's going to be positive. That means it is normal. That is like this. Okay, along plus 120 degree. Now, how do you calculate the resultant of all this three? So so just like how I have given you. Uh, okay, just like I've given you, it's going to be lead 1, lead 2, and lead 3. How do you calculate the resultant? I'll just show you one simple trick. So if lead 1 is like this, that means lead 1 is placed somewhere between these two. Okay, I'm just giving you an idea of how it is happening. It can be a bit confusing in the beginning. You just have to see where all the three are overlapping or falling, right? Where the resultant is going to be. So if lead 1 is there, that means spread over 0 to 180. Okay, how about lead 2? Lead 2 is here. So you can say that it's spread between this and this, because it is going to be 90 degree to the right, 90 degree to the left. So lead 2 is going to be here. It's falling here. Now about lead 3. Lead 3 is here, right? So the 90 degree to the right, 90 degree to the left. So it's falling here. Now see where all three are overlapping. Where all three are overlapping. Where is all three overlapping? Okay, let me make it clear. Where is all three overlapping? Here you have lead 1 and lead 2, right? And lead 3. Okay, so what is this? What is this axis going to be? So if lead 1 is positive, lead 2 is negative, lead 3 is positive, then the resultant is going to be somewhere over here. So it's going to be a left axis deviation. Left axis, sorry about that. It's going to be a left axis deviation. We'll give one more example so that it becomes clear. Suppose this is lead 1, this is lead 2, and lead 3 is negative. Lead 1, lead 2, lead 3 is negative. So lead 1 is going to be positive, lead 2 is going to be positive, lead 3 is going to be negative. Where is it falling? So the resultant is going to be, you can see that instead of coming down here, it's going up a little bit to the left side. That is called left axis deviation. Right? Another example. Another example is when you have lead 1 is negative, lead 1 is negative, lead 2 is positive, lead 3 is also positive. Okay, so lead 1 is negative means it's over 180 degree, lead 2 is positive, lead 3 is positive. Where is the resultant coming? It's coming a little bit to the right side. So that is called right axis deviation. It can be a little bit overwhelming and confusing in the beginning. You just have to come to this part and see how it is. If you have any doubt, please put a comment down below. This is one way of calculating the cardiac axis. Okay. Now, you have calculated the rhythm, rate, and axis from the ECG. Now, what are the normal parameters that you must remember so that you know if there is any abnormality in that ECG? So P wave, what is the basis? It's atrial depolarization. It's going to be 120 millisecond or 3 small squares. If it's more than that, it's called a large P wave, right? It's usually 3 small squares wide and 3 small squares in amplitude. So it's like a square wave. Okay, usually it's less than 2.5 mm in limb leads in terms of the amplitude, and less than 1.5 mm. It's even lesser in chest leads. And in P wave, what are the abnormalities that you can see? P wave can be a little bit taller. That's called P pulmonale. P pulmonale. P pulmonale means peaked P wave. Peaked P wave. And pulmonale means it is pointing towards the right sided etiology, right? So P pulmonale is right ventricular, right atrial hypertrophy. And P mitral is a little bit wider P wave. Mitral means wider. Okay, M is similar to W, so you can see wider P wave is P mitral. Mitral means a left sided etiology, so it's a left atrial hypertrophy. Okay, so that is the abnormalities in P wave. What about QRS complex? QRS is due to ventricular depolarization. It's usually 2 to 2.5 small squares in duration, that is 80 to 100 millisecond. You have to see if the QRS is wider, that you can see in ventricular tachycardias, or if it's a narrow complex, if there is narrow complex QRS and tachycardia, it can be a supraventricular tachycardia. T wave is due to ventricular repolarization. T wave is less than 5 mm in lip leads, less than 10 mm in chest leads. If it's more than that, it's a hyperacute T wave, which can be in early part of MI. Tall peak T wave can be seen in hyperkalemia. Usually the potassium abnormalities. Hypokalemia can be an absent T wave with a U wave. Hyperkalemia can be a tall peak T wave. So T wave abnormalities may be with electrolyte abnormalities. PR segment is the AV nodal conduction. So you have to see if the PR segment is prolonged or the PR interval is prolonged. PR interval is prolonged in heart blocks. ST segment, it has to be isoelectric. If there is any elevation or depression, it can be due to MI or any other pathology like pericarditis. Also, you can get a uniform uh, ST segment elevation. PR interval, usually it's 120 to 200 millisecond. Anything more than 200 millisecond, it's called a prolonged PR interval. QT interval is 360 to 440 millisecond. In males and females, there is a little bit different, but anything more than 450 can be considered as a QT prolongation. So avoid drugs that can predispose them to further torsitis, depointers, and fatal arrhythmias. Okay, so we have discussed this. P pulmonale is seen in right atrial hypertrophy, P mitral in left atrial hypertrophy, absent P wave in case of atrial fibrillation. Because P wave is atrial contraction, if there is no effective atrial contraction, you can't get a P wave. Prolonged PR interval, heart block. Short PR interval. Short PR interval with a slurred QRS, that is seen in case of WPW syndrome, because there is an alternate pathway in addition to the normal pathway. That's called bundle of Kent. Okay, it's like a re-entrant tachycardia. So WPW or Wolf Parkinson White syndrome, you can have a short PR interval. Pathological Q wave in case of MI, it can be in old MI also, because once a Q wave is established, it may not go back. So it's a pathological Q wave. Narrow QRS complex in case of supraventricular tachycardia, wide QRS complex in case of ventricular tachycardia. ST elevation or depression. ST elevation can be in ST elevation MI for sure, but can be seen in other cases like pericarditis as well. Hyperacute T wave in hyperkalemia. Potassium is high. T wave in case of non-ST elevation MI, or in late part of pericarditis also you can get a T wave inversion. Absent T wave with U wave, both of this seen in hypokalemia. Potassium is low. Okay, I've added this again. P pulmonale, right atrial hypertrophy. P mitral, left atrial hypertrophy. Absent P wave, atrial fibrillation. Prolonged PR interval, first degree heart block. Short PR interval with a slurred QRS, WPW. Pathological Q wave, old MI. Narrow QRS, SVT, wide QRS, ventricular tachycardias, ST elevation in ST elevation MI or pericarditis, hyperacute T wave in hyperkalemia or early part of ischemia. Because in ischemia, the first change is not ST elevation, it's going to be hyperacute T wave. T wave inversion in case of non-ST elevation MI, absent T wave and U wave in case of hypokalemia. Now, QT prolongation, I've talked about this. It can be due to drugs or it can be a congenital long QT syndrome. Now, congenital long QT syndrome can predispose a patient to, again, torsitis, depointers, and fatal arrhythmia and sudden cardiac death. So, sudden cardiac death can be due to many things, especially in young adults who are athletes. The question may suggest that the patient is having HOCM, hypertrophic obstructive cardiomyopathy, or it can be a Brugada syndrome, wherein there can be again fatal arrhythmias, or it can be a congenital long QT syndrome, where the patient can have torsitis, depointers, and sudden cardiac arrest and cardiac death. Now, there are drugs which are predisposing to QT prolongation and this fatal arrhythmias. Those are antiarrhythmics like amiodarone, sotalol, antidepressants like tricyclic antidepressants, anti-epileptic like levetiracetam, antibiotic like erythromycin and ondansetron, and dyselectrolytemia like hypokalemia, hypomagnesemia, hypocalcemia, anything can. predisposed to torsitis depointis. Torsitis depointis is actually it is a polymorphic VT. So it is going to be a polymorphic ventricular tachycardia. So it is like circling around a point. That's what the term means. Torsitis depointis, right? And the management is going to be magnesium sulfate. Even if magnesium turns out to be normal in the lab values, the initial management of torsitis depointis is IV magnesium sulfate. Okay, so those are regarding the main ECGs and everything. We'll discuss about arrhythmia in the coming session. Thank you so much.